Today we are going to discuss about vitamin B12, its deficiencies and diagnosis. What is vitamin B12? As you all know, vitamin B12, also called cobalamin, is an essential factor in the production of red blood cells. People who do not have enough B12 in their system suffer from anemia. B12 is also necessary for the production of other blood cells, as well as normal neurologic functions. Someone with severe vitamin B12 deficiency may have anemia, as well as a variety of neurologic and psychiatric problems. These symptoms can be mild as irritability, a slight memory loss, and the sensation of pains and the needless in extremities. They can be severe, including, among other things, shaky, unsteady gait, weakness, incontinence, peripheral neuropathy, dementia, and psychosis. One disease associated with low levels of B12 was known even before the specific vitamin was discovered. It was called pernicious anemia. Doctors knew that something collected in animal livers cured the disease, so people with the pernicious anemia were effectively treated with large amounts of liver. Eventually, the vitamin was isolated and its chemical composition is understood. Research has led to much greater knowledge of B12 and its role in health as well as disease. Vitamin D is necessary for normal DNA synthesis. It works along with folic acid in a wide variety of ways. Normal amount of vitamin B12 and folic acid are necessary to prevent a substance called homocysteine from accumulating in the body. Elevated homocysteine levels are implicated in many common medical problems, including cardiovascular disease, neurologic disorders, and cancer. It is somewhat difficult to look at vitamin B12 in isolation from folic acid. Vitamin B12 and folate are closely related. Each depends on the other for activation. Vitamin B12 removes a methyl group to activate the folic coenzyme. When folate gives up its methyl group, the vitamin B12 coenzyme becomes activated. The regeneration of the amino acid methionine and the synthesis of DNA and RNA depends on both folate and vitamin B12. Without any help from the folate, vitamin B12 maintains the sheath that surrounds and protects the nerve fibers and promotes their normal growth. Bone cell activity and metabolism also depend on vitamin B12. In the stomach, hydrochloric acid and the digestive enzymes pepsin release vitamin B12 from the proteins to which it is attached in food. As the vitamin passes to the small intestine, it binds with a molecule called intrinsic factor. Bound together, intrinsic factor and vitamin B12 travel to the end of the small intestine when receptors recognize the complex. The receptors do not recognize vitamin B12 along without intrinsic factor. There the intrinsic factor is degraded and the vitamin is gradually absorbed into the bloodstream. Transport of vitamin B12 in the blood depends on specific binding proteins. Folate vitamin B12 follows the enterohepatic circulation route. It is continually secreted into bile and the liver to the intestine, where it is reabsorbed because most vitamin B12 is reabsorbed. Healthy people rarely develop the deficiency even if their intake is minimal. B12 became known as a pick me up for a whole generation of people. People with pernicious anemia given B12 injections started making more red blood cells, and as their anemia went away, they got back their normal energy. What worked for one person feeling tired seemed like it might work for other people that were tired. Patients would go to the doctor and ask for their monthly B12 shot. Most doctors do not give B12 injections for this reason anyone, but it was not that long ago when they did. Elevated homocysteine levels have been found in a wide range of common and less common medical problems. B12 with or without folic acid can lower levels of homocysteine. There is a lot about this that is not well understood yet. Are elevated homocysteine levels the cause of this disease or just a marker for some other problem? Will giving B12 to people with elevated homocysteine levels actually lowers the risk or even they help cure some of these diseases? Is this hype or are these actual studies to answer these questions? Here are some of the problems as associated with low B12 and high homocysteine level. Since a lack of B12 is known to cause dementia, depression, and other neurologic and psychiatric disorders, researchers have considered the possibility that low B12 levels might be found in patients with these conditions. Researchers have found low levels of B12 in elderly patients with depression, patients with Alzheimer's disease and other cognitive disorders, and even psychosis. In many studies, such as the Rotterdam study published in 2002, participants were found to have elevated homocysteine levels along with the lowered levels of B12. There is the homocysteine hypothesis of depression, which postulates that elevated homocysteine levels may cause depression. Anything decreasing the homocysteine might help the patients with depression, including supplements of B12. In many studies, there is a homocysteine hypothesis of depression. Decreasing homocysteine might help the patients with the depression, including the supplements of vitamin B12. A similar mechanism involving elevated homocysteine may contribute to symptoms of Alzheimer's disease and dementia. Some studies have found lower B12 levels but not elevated homocysteine levels associated with declining cognitive functions. Even if patients with low B12 levels or high homocysteine levels are more likely to be depressed or have difficulty with cognition, such as what is found in Alzheimer's disease. Does that mean that supplements will improve their symptoms? This is the question that has to be answered in the relationship to B12 and many neurologic and psychiatric conditions. Since the level of B12 affects the level of homocysteine, and high homocysteine levels are associated with higher risk of cardiovascular disease, including coronary heart disease and stroke. It has been suggested that B12 supplementation might lower the risk of these conditions in patients with elevated homocysteine. Since B12 is necessary for DNA synthesis, low levels of the vitamin might hinder cell repair and lead to higher incidence of cancer. Perhaps supplemental B12 can reduce the risk of cancers. Lower rates of colon cancer and cervical cancer may be related to higher B12 levels. There are a number of other conditions that may be related to low B12 levels. They are also often associated with low folic acid level and elevated homocysteine levels. Folic acid is known to be necessary to prevent the defects in the neural tube of the developing embryo. They are also often associated with low folic acid levels and elevated homocysteine levels. Folic acid is known to be necessary to prevent the defects in the neural tube of the developing embryo. In some people, vitamin B12 may also be necessary. High levels of homocysteine may be related to the early pregnancy, loss, and preeclampsia. This may be secondary to insufficient B12. Macular degeneration, a deterioration of the retina that can lead to blindness, is associated with high levels of homocysteine. It is possible that B12 might help treat this condition. There are many other conditions that may be related to elevated homocysteine levels or low B12 levels. Most vitamin B12 deficiencies reflect inadequate absorption, not poor intake. Inadequate absorption occurs for one of two reasons: a lack of hydrochloric acid or a lack of intrinsic factor. Without hydrochloric acid, the vitamin is not released from the dietary proteins and so is not available for binding with the intrinsic factor. Without the intrinsic factor, the vitamin cannot be absorbed. Many people, especially those over 50, develop the atrophic gastritis, a common condition in older people that damages the cell of the stomach. Atrophic gastritis may also develop in response to iron deficiency or infection with Helicobacter pylori, the bacterium implicated in ulcer formation. Without healthy stomach cells, production of hydrochloric acid and intrinsic factors diminishes. Even with an adequate intake from food, vitamin B12 status suffers. The vitamin B12 deficiency caused by the atrophic gastritis and a lack of intrinsic factor is known as pernicious anemia. Some people inherit a defective gene for the intrinsic factor. In such cases, or even with the stomach has been injured and cannot produce enough of the intrinsic factor, vitamin B12 must be injected to bypass the need for intestinal absorption. The vitamin may be delivered by the nasal spray alternatively. Absorption is rapid, high, and well tolerated. A prolonged inadequate intake, as can occur with a vegetarian diet, may also create a vitamin B12 deficiency. People who stop eating foods containing the vitamin B12 may take several years to develop the deficiency symptoms because the body recycles much of its vitamin B12, reabsorbing it over and over again. Even when the body fails to absorb vitamin B12, deficiency may take up to 3 years to develop because the body conserves its supply. Because vitamin B12 is required to convert the folate to its active form, one of the most obvious vitamin B12 deficiency symptoms is the anemia of folate deficiency. This anemia is characterized by large, immature red blood cells, which are indicative of slow DNA synthesis and an inability to divide. When folate is trapped in its inactive form due to the vitamin B12 deficiency or is unavailable due to folate deficiency itself, DNA synthesis slow. First to be affected in a vitamin B12 or folate deficiency are the rapidly growing blood cells. Either vitamin B12 or folate will clear up the anemia. But if folate is given when vitamin B12 is needed, the result is disastrous, devastating neurological symptoms. Always remember that vitamin B12, but not the folate, maintains the sheath that surrounds and protects the nerve fibers and promotes their normal growth. Folate cures the blood symptoms of vitamin B12 deficiency, but cannot stop the nerve symptoms from progressing. By doing so, folate masks a vitamin B12 deficiency. Marginal vitamin B12 deficiency impairs the performance on tests measuring intelligence, spatial ability, and short-term memory. Advanced neurological symptoms include a creeping paralysis that begins at the extremities and work inward up the spine. Early detection and correction are necessary to prevent the permanent nerve damage and paralysis. With sufficient folate in the diet, the neurological symptoms of vitamin B12 deficiency can develop without evidence of anemia. Such interactions between the folate and vitamin B12 highlight some of the safety is issues the surrounding the use of supplements and the fortification of foods. No adverse effect has been reported for excess vitamin B12 and no upper level has been set. There are two specific enzymatic reactions in the body that are dependent on B12. The one that has received the most attention in the conversion of homocysteine to methionine. When there is a lack of B12, homocysteine level rise. Elevated homocysteine levels are being discovered in a wide variety of diseases. As noted elsewhere in the other reactions involving the conversion of methylmalonic acid to succinyl CoA. B12 is needed for normal DNA synthesis. It is needed to make the blood cells when there is not enough B12. Not enough red blood cells are made, eventually with severe deficiency. Other blood cells will also decrease. The nervous system needs B12 and will show the effects of deficiency. Vitamin B12 and folic acid work together in the body. In many cases, it is difficult to separate their effects. It is clear that vitamin B12 is necessary to all people for good health. It is indicated as a supplement for anyone who is deficient in B12, who develops a B12 deficiency. B12 exists in nutrients that come from animal tissues. Normally, B12 in food must be separated from the food in the stomach. It is there the intrinsic factor, made by parietal stomach cells, attaches to B12. The combination of B12 intrinsic factor continues down the intestinal tract to the end of the small intestine called the terminal ileum. It is absorbed through the lining of the ileum and from there into the bloodstream. It binds to the transcobalamin too and can then travel to the rest of the body. The original understanding of the B12 came from the study of the people with pernicious anemia. Pernicious anemia is an autoimmune disorder, a disorder in which the body mistakenly attacks itself. In this case, the body makes antibodies against the cells in the stomach that make intrinsic factor. People without intrinsic factor have trouble absorbing food-bound B12. They develop pernicious anemia. Most people get enough B12 in their diet and in fact have enough stored in their body that it takes years to develop a deficiency. Strict vegans can become low on B12 if they never eat anything from an animal source, as can the elderly and alcoholics, who may not be ingesting enough B12. More commonly, people who do not have enough hydrochloric acid in their stomachs develop B12 deficiency. The acid is needed to dissolve the B12 from its food sources. Elderly people can become B12 deficient because they develop atrophic gastritis and their stomachs does not make enough acid. People of all ages take histamine blockers and proton pump inhibitors to stop heartburn. These medicines are available over the counter. Acid suppressed over a long period of time, people can develop a deficiency of B12 because it does not get separated from food. Other less common causes include other causes of malabsorption in general, such as inflammation in the intestine from Crohn's disease, tapeworm, and bacterial overgrowth. Surgery involving removal of parts of the stomach or small bowel can also contribute to B12 deficiency. It is possible for vitamin B12 deficiency to occur without anemia and even with apparently normal blood levels of B12. It may be necessary for other blood tests to be done in order to diagnose B12 deficiency, including checking homocysteine and methylmalonic acid levels. It is also possible for psychiatric and neurologic diseases to be present without anemia. Anyone who might be at risk for B12 deficiency needs to keep this in mind. In one study, 20% of elderly patients had underdiagnosed vitamin B12 deficiency. Some doctors give B12 and folic acid to elderly patients for this reason. There is evidence that people with the higher levels of B12 improve faster when treated for depression. Some psychiatrists are giving B12 to patients treated for depression. One study showed that giving women at risk for cardiovascular diseases supplements of vitamin B, including B12, lowered the risk of macular degeneration. Injections are not necessary for B12 deficiency or pernicious anemia. Large doses by mouth work just as well. There are apparently other pathways by which B12 is absorbed in small intestine. If enough is taken in, enough will be absorbed. Oral doses of 1000 to 2000 microgram per day are enough to correct deficiency but have to be taken for life. If the cause is pernicious anemia or something else that cannot be corrected. Alternatively, B12 can be given by injections into the muscles. 100 to 1000 microgram must be given every day or every other day for 1 to 2 weeks, followed by shots of 100 to 1000 microgram every 1 to 3 months for life. The recommended dietary allowances for B12 is 2.4 microgram per day for healthy adult males and females. This goes up to 2.6 microgram a day for pregnant and breastfeeding women. Most people consume much more than this is their diet. They are not absorbing B12, they need to take a supplement containing large amounts of B12. B12 is very safe to use and well tolerated by most people. There are no established adverse effects from taking too much B12. There have been reports of itching and rash following ingestion of B12 and also reports of diarrhea. B12 and pyridoxine together have been associated with rosacea fulminans, which may need to be treated with steroids. Vascular thrombosis has been reported. B12 replacements can make other hidden illnesses apparent, including the polycythemia vera. B12 should not be taken by patients who are going to have coronary artery stents placed on, who have Leber's disease, hereditary optic nerve atrophy. There is proof that people with the cardiovascular disease, heart attacks, and strokes have elevated homocysteine levels. Vitamin B12 deficiency can cause elevated homocysteine levels. There is no proof at the current time that using the B12 to lowering the homocysteine levels will actually lead to less cardiovascular disease, strokes, heart attacks, or deaths from the cardiovascular causes. It may be that further studies with large groups of people over longer periods of time will show that B12 supplements to improve cardiovascular health. Or it may be that homocysteine is a marker for something else that is actually causing the damage, and the something else may need to be addressed. There are conflicting studies about the B12 supplements for neurologic or psychiatric problems. Some have been shown the benefits to giving the patients with Alzheimer's disease B12 with or without folic acid. Some have not. There is evidence that many elderly patients are deficient in B12 without being anemic and go undiagnosed. So it may be that B12 supplements are really helping patients whose memory problems and other difficulties are actually caused by vitamin B12 deficiency. Adding B12 has been shown in some studies to help the people recover more quickly from depression. Considering the fact that B12 is very safe to use and inexpensive, it seems reasonable to try supplements for the people with depression or Alzheimer's disease and other similar conditions. It is also important to make sure that vitamin B12 deficiency is not overlooked, especially in the elderly. The data in regard to neural tube defects are conflicting, and it is difficult to separate the folic acid, B12 deficiency, and elevated homocysteine levels. This is also true for a lot of the studies looking at cancer and B12 levels. There is a possibility that genetics may determine whether or not a B12 deficiency poses greater risk for certain people than others. It may be some times before there is more certainty regarding the use of supplementary B12 for the variety of conditions. Next mineral which I am going to discuss about folate. Folic acid is the name given to the synthetic form of folate, one of the water-soluble B vitamin. It was identified some 70 years ago as a substance that could prevent anemia during pregnancy. Folate was ultimately extracted from spinach leaves and its chemical structure identified. Folate is essential for normal cellular growth because it has an indispensable role in DNA synthesis. When cells are growing and dividing quickly, such as during pregnancy, folate is even more important. Folate also helps maintain normal levels of the amino acid homocysteine. While homocysteine is needed in order to make proteins, elevated levels of homocysteine have been implicated in a wide variety of disease processes, from cardiovascular diseases to cancer. Folate has a chemical name that would fit a flying dinosaur: tyroyl glutamic acid. Its primary coenzyme form, which is THF tetrahydrofolate, serves as a part of an enzyme complex that transfers one carbon compound that arises during metabolism. This action helps convert vitamin B12 to one of its coenzyme forms and helps synthesize the DNA required for all rapidly growing cells. Foods deliver folate mostly in the bound form, that is, combined with a string of amino acid known as polyglutamate. The intestine prefers to absorb the free folate form, folate with only one glutamate attached, the monoglutamate form. Enzymes on the intestinal cell surfaces hydrolyzed the polyglutamate to monoglutamate and several glutamates. Then the monoglutamate is attached to a methyl group. Special transport system delivers the monoglutamate with its methyl group to the liver and other body cells. In order for the folate coenzyme to function, the methyl group must be removed by an enzyme that requires the help of vitamin B12. Without that help, folate becomes trapped inside cells in its methyl form, unavailable to support DNA synthesis and cell growth. To dispose of excess folate, the liver secretes most of it into bile and ships it to the gallbladder. Folate returns to the liver in an enterohepatic circulation route like that of bile itself. This complicated system for handling the folate is vulnerable to GI tract injuries. Folate is actively secreted back into the GI tract with bile. It has to be reabsorbed repeatedly. If the GI tract cells are damaged, then folate is rapidly lost from the body. Such is the case in alcohol abuse. Folate deficiency rapidly develops and damages the GI tract further. The folate coenzymes, remember, are active in cell multiplication and the cells lining the GIT tract are among the most rapidly renewed cells in the body. Unable to make new cells, the GI tract deteriorates and not only loses the folate, but also fails to absorb other nutrients. The many studies elevated blood levels of homocysteine have consistently been observed in patients with cardiovascular disease. This includes coronary artery disease leading to the heart attack and disease of the blood vessels to the brain, which can cause a stroke. This raises the question, is homocysteine causing any of these problems? Many other conditions have been associated with cardiovascular disease and have been found to contribute to the damage. High blood pressure, for example, is not only associated with cardiovascular disease but also worsens it. Controlling high blood pressure can reduce the injury to blood vessels. In the same way, lowering elevated cholesterol can prevent or even help decrease the existing fatty plaque that are clogging blood vessels. It is not clear if homocysteine is just a marker for cardiovascular disease or is actually a risk factor that contribute to it. Most of the evidence is observational only. People with higher homocysteine levels have higher rates of cardiovascular disease. Homocysteine could actually cause vascular injury in a number of ways. It has been observed that homocysteine can reduce the normal vasomotor functions of the vascular endothelial cells that line the blood vessels, which would affect blood flow. Homocysteine may cause damage to coronary arteries directly and may cause platelets to clump, which can cause a clot. Folate deficiency causes higher homocysteine levels. Administering folate with or without other B vitamins lowers homocysteine levels. The question then becomes, does lowering homocysteine levels actually decrease the risk of cardiovascular disease? This has to be decided by the clinical trials. It must be kept in mind that different countries implemented folic acid fortification of grains and cereals at different times during the last 10 to 20 years. In the world, fortification was in place by 1998. Most people eat enough grains and cereals that the average amount of folic acid ingested in this country significantly increased. Most of the observational studies were finished and reported in the mid to late 1990s before fortification programs were started. A picture you can see here, this photo taken in 2003 provided by the March of Dimes shows a young woman with spina bifida living in a rural village in South Africa. The child on the woman's back at right belongs to the woman in the wheelchair. That child was helped to be born healthy because the woman with spina bifida took the B vitamin folic acid beginning before pregnancy. About 8 million children worldwide are born every year with a serious birth defect, many of whom die or are disabled. A stunning and largely hidden toll, says research released by the March of Times. The report found that while birth defects are underappreciated globally. Most occur in poor countries where babies can languish with problems easily fixed or even prevented in wealthier nations. There have been studies using folate together with other B vitamins to lower homocysteine levels in an attempt to decrease cardiovascular disease. In one trial, 3,749 people who had just suffered heart attacks were randomized to receive vitamin, either 0.8 mg of folic acid, 0.4 mg B12 and 40 mg B6, 0.8 mg folic acid and 0.4 mg B12, 40 mg of 30 B6 or placebo. They were followed for 40 months, looking for recurrence of a heart attack, a stroke, or sudden death from the heart disease. Homocysteine levels were lowered by an average of 27% in the patients given folic acid plus B12. There was no observed benefits in the group given all three vitamins. There was a slightly increased risk of heart attack. The HOPE trial published results at the same time in 2006. More than 5,000 patients aged 55 or older with vascular disease or diabetes received 2.5 mg of folic acid, 50 mg of B6, and 1 mg of vitamin B12 or placebo for 5 years. Investigators were looking for death from cardiovascular disease, heart attack, or stroke. Again, homocysteine levels were lowered, but the risk of major cardiovascular events was not. In 2008, the results were published of a trial involving more than 8,000 female health professionals at high risk for cardiovascular disease, called the Women's Antioxidant and Folic Acid Cardiovascular Study. The result was similar to those found in the HOPE studies. Other studies were continuing during this time period. The SEARCH trial used 2 mg of folic acid plus 1 mg of vitamin B12 in a randomized placebo-controlled trial involving more than 12,000 patients, followed for 10 years. Homocysteine levels were lowered, but there were no observed benefits in terms of cardiovascular disease. These patients were also followed for cancer incidence and it was not any higher in the treatment group than placebo group. The researchers in this study stated unequivocally that folic acid does not produce any beneficial effects as far as cardiovascular disease is concerned. It is possible that baseline folate levels in some of these studies could have been higher because of folic acid fortification of grains. Perhaps homocysteine levels and cardiovascular risk are only related when people are relatively deficient in folate. Folic acid does not improve the cardiovascular disease in subgroups of patients such as those with the chronic kidney failure. High-dose folic acid reduces the homocysteine but not adverse cardiovascular events. The homocysteine hypothesis also applies to stroke. There are researchers who believe that lowering homocysteine with folic acid supplementation does lower the risk of stroke. This is based on analysis of studies in which folic acid was given and stroke was one of the reported endpoints. For example, the HOPE trial, looking just at stroke and not all cardiovascular events, Some evidence in these studies thus seems to indicate folic acid may lower the risk of stroke. More research needs to be done. The relationship between folate and cancer has been called the dual effect of folate. Folate has been called a dual modulator. This is because folate is needed for both normal cell growth and cancer cell growth. While there is evidence that higher folate levels can lower the incidence of cancer, there is also evidence that supplemental folate can cause increased incidence of cancer. It has been suggested that folate may be useful if there are absolutely no precancerous cells in the body, but that if any precancerous lesions are there, excess folate may increase the incidence of cancer and the growth of cancer. There has been at least limited evidence found for a protective effect of folate, possibly decreasing the incidence of breast, lung, pancreas, mouth, esophagus, stomach, cervix, ovary, and certain other cancers. There have been a number of good quality studies allowing for larger analysis that seems to confirm the protective effect of folate against esophagus, stomach, and gastrointestinal cancers, and to a lesser extent breast cancer. Colorectal cancer has been studied the most. There had been consensus from many trials, both case-control studies and prospective cohort studies, that higher level of the folate consumption and higher levels of the blood folate are associated with lower risk of both colorectal cancer and the precancerous polyp. The scientific explanation is thought to be that folate is critical cellular processes like normal DNA synthesis. Abnormalities of these processes can lead to the cell becoming malignant. The decrease in risk is not always apparent unless the study follows the participant at least 10 to 15 years. Some prospective studies have found a surprising increase in adenomas in patients given the folic acid after detection and removal of a first polyp. This takes some 6 to 8 years to be apparent. It is possible that the dual effect, possibly protection versus increasing incidence, may have to do with timing as well as baseline folate level. People free of any cancerian or precancerian cells may gain protection from folate. Folic acid may cause even tiny amounts of cancerian cells to grow, and therefore folate supplements may increase the incidence of cancers in some groups. There may be factors such as genetic variations in various enzymes and whether or not a person smokes, as well as many other factors that contributes to the dual outcome. One 10-year trial showed no decrease in the incidence of colorectal polyps, but rather a possible increase. It has been suggested that folic acid, which is not the natural form of folate, may be responsible for some of the negative effects of folate supplementation, like the increased risk of cancer. At high doses, folic acid itself appears in the blood because the large amounts overwhelm the conversion of folic acid to 5-methyl tetrahydrofolate. Looking at the larger population, the incidence of colorectal cancers, which was decreasing, started to rise again after the introduction of mandatory grain fortification that began in 1996 and was fully implemented by the 1998. There is informed speculation that there may be a relationship between these two things. It is not possible to say whether or not folic acid can protect against the colon cancer. It probably depends to some degree on individual genetic factors and whether or not there are any small loci of early cancer already present. In one trial designed to evaluate the effect of folic supplementation on colon polyps, the data were also analyzed in regard to prostate cancer. In this study of approximately 700 men, folic acid supplementation was associated with a higher risk of prostate cancer, while higher dietary intake of folate as well as higher measured folate levels showed a possible association with a lower risk of prostate cancer. This trial was not designed to evaluate the prostate cancer risk. In at least one study, there was an increased risk of breast cancer found in women taking the folic acid supplementation. A recent study showed that 40% of the older adults in the United States have unmetabolized folic acid in their blood, considered a possibly cancer risk. The homocysteine hypothesis also applies to central nervous system functions. Most studies have not shown an improvement in cognitive function with folate supplementation, even when homocysteine levels are lowered. An analysis of cognitive function as a secondary endpoint in the trial, which was set up to evaluate the effects of folic acid on cardiovascular endpoints, did find a beneficial effect of folate on sensitive cognitive function tests. In the study, approximately 800 people were randomized to take either 800 microgram of folic acid or placebo for 3 years, and those who took folic acid performed better on a number of tests. In some studies, a low folate level has been a risk factor for dementia. On the other hand, elderly patients given folic acid who are low in B12 can manifest a number of neurological abnormalities. These include problems with memory and cognition. On an individual level, knowing B12 and folic level and taking the both supplements if needed is best. But in terms of fortifying food and recommending journal supplementation, it is impossible to know who might need B12. There is some evidence that low folate levels are associated with depression and that administration of folic acid or other forms of folate may improve treatment results with antidepressants or even mitigate the need for antidepressants in some individuals. There is no question that low folate levels are related to fetal neural tube defects. Low folate level may also cause other problems during pregnancy. These may include other birth defects. Low folate has also been linked premature birth and low birth weight. There may also be a relationship between low folate levels and miscarriages, preeclampsia, and abruption of the placenta. While the risk of neural tube defects is specific to early pregnancy, many believe that folate intake should remain high because of the other possible risk. In general terms, folate deficiency usually is the result of inadequate intake or the inability of the intestine to absorb folate. It can also occur as the result of increased demand without increased intake, for example during pregnancy and breastfeeding. Inadequate intake was common before the FDA mandated enriching grains with folic acid. Certain individuals are more likely to have folate deficiency. This can be because of decreased intake, decreased absorption, or increased need. People with the kidney failure getting the dialysis, which causes a loss of folate. People with other liver diseases, which cause a loss of folate. People with intestinal diseases that interfere with the folate absorption. People taking the medications that interfere with folate metabolism, including but not limited to anticonvulsants, metformin, methotrexate. As an example, methotrexate can be taken for cancer or autoimmune diseases and interferes significantly with folate metabolism. People taking this medication need to ask their physician exactly what form of folic acid that they can take without causing the methotrexate to be less effective. Mild folate deficiency causes few symptoms. Babies and children who don't get enough folate will not grow at a normal rate. Adults who are folate deficient develop a specific kind of anemia. The babies born to the folate deficient pregnant women are more likely to be preterm, low birth weight, or have a congenital anomaly called a neural tube defect. While the anemia is the best known abnormality associated with low folate levels, other symptoms in adults include the loss of appetite, diarrhea, weight loss, and a smooth tongue. With progressive folate deficiency, weakness, fatigue, shortness of breath, headache, irregular heart rhythms can also occur. A change in behavior may be observed by others, as can irritability and worsening memory. The anemia is called megaloblastic or macrocytic because the immature red blood cells produced are larger than normal. There can also be abnormalities seen in certain types of white blood cells. Since the life of a red blood cells is usually 4 months, individuals deficient in folate will not become anemic for a number of months. Deficiency of vitamin B12 presents a similar picture. Some with low folate, such as people with celiac disease, also have elevated homocysteine level that can be corrected with treatment of the underlying disease. This is another reasons to take extra folate. Some have suggested that 5-methyl tetrahydrofolate might be a better supplement than folic acid. Many of the symptoms can be caused by other diseases or nutritional deficits, so a physician needs to make the diagnosis. Folic acid level can be measured along with other tests that can help confirm the deficiency. B12 level must be evaluated in folate deficient individual.